The following case summary demonstrates implant placement in a 20-year-old female who presented with an acid-etched bridge that was used to restore her congenitally missing maxillary right lateral incisor. The patient presented with a cuspid and central incisor that were minimally prepared on the palatal aspect to support the wings of the acid-etched bridge. The acid-etched bridge was indeed nice and aesthetic. However, the patient was mainly concerned about long-term function. There was no indication to prepare the adjacent teeth for a conventional 3-unit bridge. Although there were no medical contraindications to implant therapy, the amount of space between the adjacent natural teeth was minimal. As mentioned earlier, the lateral incisor site can present some difficulties when surgically placing dental implants. The facial palatal width is often compromised, especially for cases in which the edentulous condition is congenital. A digital periapical radiograph of the edentulous site indicated, however, that there was enough space to surgically position and accept the dental implant. Though there was limited space at the maxillary right lateral incisor site, radiography indicated that there was sufficient bone volume for the placement of an implant. When placing an implant, the practitioner needs to be certain that the angulation, depth, and position of the implant are appropriate to allow for a natural emergence profile. For this case, a scan was taken using the PAX i3D green imaging system from Vratech America in New Jersey. The sagittal view of the scan illustrates the amount of vertical and horizontal bone that was available. The amount and quality of bone was precisely determined with the imaging software. Virtual placement of the implant was also performed, helping the practitioner select the appropriate implant size and visualize how the implant should be positioned in the edentulous space. Because I felt comfortable with the anatomy presented, the implant was placed without the use of a surgical guide. After treatment planning, the acid-etched bridge was easily removed from the adjacent teeth. This revealed a defect in the facial contour of the edentulous space. Due to the lack of interseptal bone, no interdental papilla was present. A pilot drill was centered between the teeth adjacent to the edentulous site. The osteotomy was positioned approximately 3 millimeters palatal to the facial aspect of the adjacent dentition to allow for the best aesthetics and enough facial room for a custom abutment and implant retained crown. The mesial distal angulation of the drill was checked with a periapical radiograph. The diameter of the osteotomy was slightly smaller than that of the implant chosen for this case, and a depth of approximately 13 millimeters was established. A 3.0 millimeter diameter Hahn tapered implant was chosen for this case. The diameter size and tapered body of the implant was ideal for the limited space that was available. Additionally, the implant features prominent threads, which eases placement and allows the clinician to thread the implant into an undersized osteotomy. The ability to place an implant in a slightly smaller osteotomy can help ensure excellent primary stability. This is especially beneficial in cases where bone quality is not optimal. Because her acid-etched bridge would function as a transitional appliance during the period of healing and osseointegration, a cover screw was hand-tightened into the implant. As illustrated in this radiograph, the implant was nicely positioned. Despite the small space that was available, a 3.0 diameter tapered implant was placed with ease. The patient's acid-etched bridge was then cemented back onto the adjacent teeth, and 4 months following surgery, the patient returned to begin the restorative process. A tissue punch was then utilized to access the healed implant site. Because of the relatively non-invasive nature of the tissue punch, the final impression was taken during the same visit. The cover screw was removed and an impression coping was hand-tightened into the conical internal hex connection of the Hahn tapered implant. Panasil vinyl polysiloxane material from Kettenbach was used to create a final impression so the dental lab could fabricate the restoration. Based on the final impression, the lab produced an inclusive titanium custom abutment and an aesthetic Bruxer anterior crown. In order to achieve symmetrical aesthetics and occlusion when the patient is only missing one maxillary lateral incisor, the dimensions of the restoration should be primarily dictated by those of the contralateral tooth. Thus, the lab aimed to mimic the shape and contours of this contralateral incisor. At the final delivery appointment, the soft tissue was once more removed using a simple tissue punch. The custom implant abutment was then placed, and the prosthetic screw was tightened. Note here that the margins of the abutment were just slightly subgingival, making removal of the cement easy and predictable. The final crown was cemented on the custom abutment, and a final radiograph verified complete seating of the restoration. The patient was pleased to have a fixed restoration that exhibits high stability, strength, and aesthetics.